I'm an endocrinologist. I'm also the medical director of inpatient diabetes at North Shore University Hospital, which is a part of the Northwell Health System. I am also an associate professor at the Donald and Barbara Zucker School of Medicine at Northwell Hofstra. So we were also supposed to have on our panel today Mr. Robert Washington, a patient who had COVID-19, but for health reasons, he's unable to join us. We usually open up with having our person who has survived COVID tell us a brief history of what happened with them. So instead, I want to open up with, for our doctors who are in the hospital, what's going on at the hospitals. A lot of people seem to be scared to come to the hospital because they're afraid they're going to contract COVID. I saw a woman about a week ago who had a foot ulcer. And unfortunately, because she waited about a week to come in out of fear for COVID, she ended up getting an amputation of her leg. So can both of you comment, because you're from two different health systems and you're serving a large number of African-American and Latino patients, on what we can see and what's going on in the hospitals?
Go ahead, Raja.
Sure. So, several months ago, as this started, it was very scary. We were in an unknown period, uncharted territory. And as you walked into the hospital, little by little, every day, an entire floor got taken over by COVID patients. So somewhere between 15 to 20 patients per floor. Over the course of the next couple of weeks, you saw COVID take over the entire hospital, where you had tents being put up in Central Park to account for the overflow, where you had the lobby converted into a ward for overflow. And it was very scary because you did not know where it was going to stop. And what you saw were many patients who just couldn't breathe. It was that simple. They came in panting, gasping, their oxygen levels were rock bottom, and they were very sick. Their blood sugars were out of control. Many were clotting. They were having strokes and heart attacks. And there was so much that we didn't know at that beginning period. Now, what's amazing, as quickly as it came, now within the hospital, there's very few patients. Many of them were chronic patients who are on the ventilator with tracheostomies who are waiting to get transferred. But it really came, it peaked, and now there's very few of them. So I'm not sure what the future holds yet as we start opening up. But it was a very, very scary time period, one that in my 30 years of medicine, I've never experienced.
Aslan, do you want me to?
Yes, if you could chime in as well. Thank you.
I think some of the things you were alluding to is people not coming in. And, and as Raja just mentioned, the hospitals have, both at Mount Sinai and Northwell very much emptied out. And the environments are very safe. So our biggest problem right now is getting people to come in when they need it. Like I literally just admitted a friend of mine over the weekend who prevented his care. He thought his chest pain was probably COVID and maybe he should just stay at home. And he came in a month too late and his heart is severely damaged. And that storyline is playing out all over, but more commonly in urban communities and communities of color, where there's already poor access to healthcare, right? There's already this institutionalized situation where people are dropping off Medicaid because they lost their jobs and they lost their insurance. So this to me is a critical moment where we got to get people to come in to see their doctors and not be afraid to come in. And if they've lost their insurance, let's get them on Medicaid. Let's get them in. I'm very worried about this. And also the chronic care, the follow-up maintenance care of, say, mammograms. I mean, we canceled thousands of mammograms because we had COVID everywhere. Those people need to get their mammograms. Their colonoscopies have to get done. We're really behind the eight ball here. We got to get people in.
Thank you. And one other thing that has come up a lot, if you look on blogs and on the internet, is that people of color are feared that they're not getting the same treatment that other people are getting. So can you comment on the fact that people are concerned that if they come to the hospital, that there's going to be care disparities in their care if they go to certain hospitals or if they're of certain ethnic groups?
Unfortunately, that's not something new. That's something that has been going on in medicine since I was a kid. I remember as a kid sitting in the emergency room, just observing when I was sick. And you saw how certain patients got treated like dirt. and, really left there and talked down to in a condescending way. And you saw how other patients got treated differently. So this is nothing new to medicine. And it is something that needs to be fixed. And that's why the recruitment of doctors who are familiar with our patient populations in underserved areas are critical to be able to give adequate care to the community. And so COVID just sort of brought that out even more. But those differences, those disparities have always been there.
I'm happy to, I think, again, to Raj's point, that I always say, COVID shined a light on, what we already knew was there. This sort of institutionalized, to me, the issues are very structural, that people of color are really, many of it's where they're working and their sensitivity to their job loss, and then their loss of insurance. And then you go down that hole where you don't have your insurance, you don't get access. And then when you get to the hospital, you're not treated the same. If you even get to the hospital and the emergency room becomes your primary care doctor, then you're not treated as well as potentially as a person, as a white patient. So all of these things just kind of pile up and create what we're seeing, which is a horrible disparity.
I think also one of the things that has been surmised, that if we had more people of color as physicians, that would help with some of these fears that people of color have about coming to the doctor. And 100 years ago, there was something called the Flexner Report, in which they found that only 2.5% of physicians were Black. And at that point, it was actually recommended that Black doctors be taught not to be surgeons, but to be hygienists, to focus on hygiene. So 100 years later, even though we're 13% of the population, there's 2.5% of our physician workforce is African-American or Black. So how would you surmise that we can do a better job of getting a more diverse workforce?
Well, go ahead, Raja.
Go.
No, I used to teach high school for many years, and I can tell you that this starts early on, that we have to prepare our communities of color, that it's the structural issues in the public school system that gets them ready. And it's the ability to do standardized tests that are just completely unfair if you don't have 45 tutors and your parents are spending thousands of dollars to prepare you for it. So you go down the line, and that's why I think these pipeline programs, which we've started, gets kids early on, maybe around that 7th, 8th grade, up and through high school. Is that going to take care of this and lift that number up to 10%? Maybe not, but we do need to start working early in the pipeline. I'm a huge fan of pipeline programs, and at Hofstra we have a few of those.
Yeah, and I think we've got to address all the other social determinants of health. So for example, housing. If you're in a home where you're too busy just trying to make ends meet and you're just barely making your rent, you can't buy books. As a kid, I needed cheap rent. My mom needed cheap rent in order to buy me books. So you can't jump way ahead in many of these programs, although I think they are important. You got to start with the basics. You got to make sure they're in a healthy, safe home where they're not spending everything on rent, so they can buy books and focus on education as opposed to focusing on survival. And, with regards to patients, what I think is interesting, when you have a white patient that comes in to see a surgeon, they're assessing the surgeon to see, is this guy qualified? When you have a Black patient coming in to see a surgeon, first thing that patient is doing is looking at the doctor, trying to figure out, does he see me? Does he see beyond my color? Does he see who I am? And then they think about, okay, is he qualified? And usually if you won the first part, you win the second part. So it's a very different patient experience depending on who you are.
And Dr. Greenford, as someone who works on the behavioral health side, could you comment on that just as well? Because I know there are very few women or people of color as well in your field, just the same as for us as physicians.
Yeah, so absolutely. So social work is almost 80% white, and most of the clinical social workers are white. And I think that we have to recognize that the ongoing racial trauma that communities of color have faced by structural violence, because racism is structurally violent, is real. I think that when we think about what's happening in our healthcare system and in all of our systems, I'm so happy Dr. Flores mentioned social determinants of health. We know that things like redlining are still real. Where we live is real. Like you're mentioning rents. Rents are not affordable. Who can afford $2,500 in rent? Like, average Brooklyn, like who can afford that? I mean, so I think that it's not just that, it's systematic ways that people have been disenfranchised and kept out of building generational wealth and kept out of these systems. And then we still often hold people of color accountable for not having the wherewithal to pull up their bootstraps when we've systematically denied them the knowledge of what a boot is, or let alone a strap. And so what that does to the human psyche is just destructive. And we know that there's a direct correlation between our mental health and our physical well-being. So many things that we're talking about, and that you guys as physicians, as an endocrinologist, I know that more than likely many of the clients that you're seeing may be people of color. And we know that unfortunately diabetes runs very high in communities of color, particularly Black community. And we also know that there's a direct correlation between anxiety and depression and diabetes. We also know that the experience of racial trauma, and just to define it, it's race-based trauma that is deeply woven and deeply connected to experiences of racism in society that are structural, that impact our physical and mental well-being. And it has been linked to anxiety, depression, and suicidality among those who are experiencing it. We know that experience of racism directly impacts your overall well-being. And then we know that there's a correlation with the physical health. And so then we know that Black and Brown communities predominantly have higher HTN, high blood pressure. See, the medical side, then I'm like writing everything in codes. High blood pressure, diabetes, anxiety, schizophrenia, bipolar. These things are also genetically passed down. So when I am able to connect with someone, I know that the reality is more than likely someone that looks like me or in that diaspora is not going to find someone like me as easily in the mental health system. And what's happening right now is people are dealing with, do I want to continue seeing my white therapist? I need to talk about my racial trauma, and I've always had to hold back who I am, right? And so now people are not necessarily able to get the help that they need or feel that. I myself, as a mental health practitioner, find it difficult to find a mental health practitioner because all of the really amazing, dope mental health practitioners are my friends. And so who am I going to, right? And so this is a conversation that we have so often. And I think until and unless we actually recognize the deeply seated and deeply embedded trauma that is associated with racism and the way that is structurally built and structurally violent against Black, Brown, and Indigenous populations, we're never going to get anywhere. It is structural. And so it takes much more beyond the individual person to address it. And the frustration, I think, that what we're seeing right now, particularly with the very necessary social uprisings, is that we have been speaking about this for years and it has been ignored. We have been talking about it. We do not need another research study to tell us of the correlation between anxiety, depression, and racism. We don't need another research study to let us know that if you do not address the social determinants of health, such as where people live, how they're educated, the food that they eat, the resources in their community, their healthcare access, that we will have bad outcomes. We know the correlation between adverse childhood experiences and lack. We know that. We know it's the zip codes that have been predominantly impacted by COVID-19 are the same zip codes that we've looked at in the seroprevalence rates for everything else that are super high. We know that. So the reality is that we're also dealing with people feeling as though they're invisible because we know these things. We've known them for decades and we've still not done anything about it.
Mr. Williams, I'm going to turn to you if you can talk about this on the governmental level, how we can address these healthcare disparities and systemic racism.
I was just sitting back listening. Usually I'm the only person on the panel talking like this. So this is pretty dope just to sit here and hear people having these honest conversations, which I really appreciate. So I was a spectator for a second. So can you just repeat the question again?
Sure, no worries. We're trying to loop you in now. We've had the doctors speak on systemic racism and healthcare disparities, but I think now on a political level, on a government level, how do you address them as our New York City public advocate?
Well, government, we're at a moment where we can either decide to go back to normal once we come out of this, or assume and accept that normal didn't work and doesn't work for folks. And so we have to create a whole new paradigm. And that really takes courage. And that's where we are. We're at a moment in time in history where we're either going to do it or we're not. And so this, the social uprising and the folks who were in the street, and I'm very glad that this is focused on healthcare, because we need to focus on policing. But I always keep saying we have to focus on all the institutions, our city, state, and country that are suffering from the same ills as policing is. And we have to, and I am trying, and others are trying to redefine what public safety is. And very often, too often, we equate public safety with policing. And we would just throw police at a problem, it solves it. And it rarely does. And so we're trying now to reframe that, exactly what was being spoken about. If you have access, the communities that have access to safe and affordable housing, the community have access to safe, quality healthcare and mental health services, quality education, quality jobs that they can afford and put healthy food on the table. Public safety looks a lot different. And so we're at a moment now where we're really trying to change that paradigm and that perception. And it's difficult because people, the danger is very often people want to feel safe even if they're not safe. And so the go-to is, I just want to see a police on the corner. Not understanding that doesn't necessarily make the thing safer, but we have to change structurally what's going on, including adding additional resources. So right now, we're really trying to push that in this government in New York City, where we said, we have to take at least $1 billion from the $6 billion police department that's been bloated and really address many of these other issues. Sadly, we have a mayor that hasn't quite received that well. Hopefully the city council will continue to push. But this is the moment that everybody has been talking about. And, to hear the folks who have been speaking about this for such a long time now retreating as we got to that moment, it's tough to watch. But we're going to look back in 2020, and this was either a time where we began to really reckon with and atone for basically enslaving an entire race of people, and how that reverberates 401 years later in 2020, or we didn't. And if we did not, we're just going to repeat this again.
And I think the point that was made earlier, to add on to your point about housing, is so important, because if you're not in a safe environment, then you will be predisposed to more health issues and more chronic diseases. And we can look at NYCHA alone. NYCHA, which used to be a combination of both Black, white, Hispanic, is now predominantly Black and Latino. About 85% of the residents are either Black or Hispanic now. And that's due to, unfortunately, discriminatory housing practices that have been occurring in this country, in which when suburban neighborhoods were set up, Blacks were not given loans or allowed to move into these areas. So very often they were forced either to rent or public housing, which, going back to Dr. Claire, cuts off generational wealth. So a lot of our brothers and sisters who are living in NYCHA have unfortunately been exposed to a lot of mold, asbestos, and has put them at risk for chronic respiratory conditions such as asthma, chronic bronchitis, COPD. So what can we do to help those people? I know Raja has done some work with it, and also Mr. Williams, Dr. Flores, and Mr. Williams, if you can comment on that. Because even though we may not live in public housing, many of us have friends and family members who may live in public housing, who, like all of us, go to work each and every day, are paying rent, but they're living in substandard conditions.
From the political side, I just want to make sure, the one thing I always want to make people understand is that this is not just Republicans. There are Democrats that have done these things for years that got us to where we are in cities and states across this country. I might make it a little hot, so I apologize. This is just me talking. But the mayor of this city is a Democrat. The governor of this state is a Democrat. They both worked at HUD. The governor was the HUD secretary. None of these things are new and should be new to them. But these are the people who have starved NYCHA and public housing for many, many years. And so we're at a time when I see bills being passed, and you're stuck with thanking the people who blocked this stuff for years to begin with. And specifically with NYCHA, the state has almost zeroed out the money that we got. The mayor has spent time lying about what was happening with lead paint and mold for quite some time. And so from the political standpoint, just saying we have a Democrat in office is not enough. There has to be accountability. There has to be funding there. There has to be us saying we are truly going to invest and make sure that public housing is habitable for a human being. We are not at that point right now. And this NYCHA is an entire city amongst itself. And what we often see, and we treat violence as a public health issue as well, what we often see, the communities that are dealing with the issues, those stats generally track with the stats where we see the type of gun violence that nobody wants to see. And we really have to understand the intersection of that. Not as an excuse, but we have to be honest about the story behind the numbers. Because if we're not honest about the story behind the numbers, we provide a dishonest solution and response.
Dr. Flores?
So I think, it's a form of segregation. And I do have a 5-minute little slideshow that I can, with pictures that I think will say a lot more than my words. Would you mind if I showed that now?
Please share your screen.
Can you see it?
Yep.
You can?
Yes, we see.
All right. So this is through my eyes. I've been working in East Harlem for over 10 years now. And this is what I see. There are two sides to Mount Sinai. It's in between the richest of the rich in the Upper East Side and the poorest of the poor in East Harlem, or if you want to call it Spanish Harlem, El Barrio. And what I see is on 98th Street, when you look out from that side of East Harlem, that side of Mount Sinai, there's a building called St. Bernard's School for Boys. And it is a $44,000 a year tuition school. It is an impressive school, and it is not a school that many of the kids from East Harlem go to. And then when I eat breakfast every morning, I sit at a counter with a window looking out at the Carver housing projects. And when I'm sitting there eating my breakfast, waiting for my day to start, there's always a family that has a special needs kid that one day the mom comes out, the dad comes out, the siblings come out to put this kid in the school bus. I see people coming out of that building, walking their kids to school, secretaries going to work who just crossed the street to come right into Mount Sinai. And what it shows me is that the people who live in NYCHA are our colleagues. They're secretaries, janitors, nurses, cops, veterans, seniors. NYCHA is full of people that actually keep our institutions going. Mount Sinai is actually the largest employer of East Harlem. And all these people live in NYCHA. And what's terrible to me is this is what they're living in. This is lead paint and it's peeling off. So if you have a kid growing up in this house and you wonder why they're not doing well in school, well, they're living in a house with lead. And I guarantee you, if the family living there can't fix this, it's because they're working so damn hard and they pay rent. It's not like they're not paying rent. They're paying rent. They're living with this. They're living with appliances that don't work. When I was growing up, many times we didn't have heat and hot water. And you realize you got to crank open the ovens and the burners and stuff, and you can't really sleep well. All that adds to your stress level, adds to cortisol being released, adds to diabetes, hypertension, etc. All this affects your health. Who cares whether you're covered for medicine, medically or not, when your own home, and home is healthcare, when your own home is not healthy and safe. And here you got flooding all the time, etc. Here you got paint falling down, and more importantly, there's mold. What happens when you have mold in there? They inhale it. Here you have patients who have mold in their lungs. This is called an aspergilloma. And you know what I have to do when I have patients with aspergillomas? This breaks my heart because this is so preventable. I have to make a big incision in their side, take out a rib, crank their chest open so I can cut out half their lung for something that is completely avoidable. This is neglect by the landlord, period. And this is happening throughout our entire city. This is pathetic. And I said to myself, I have to get the word out there because nobody knows this. And you know what? I did my homework and I found out last year, they actually did their homework. The Department of Health for the state of New York, funded by Andrew Cuomo, put this out. This is on the internet. And you know what they found? 83% of the apartments in NYCHA had a severe health hazard. 83%. Mold, asbestos, lead, roaches, mice. You have smoke seeping in through all the cracks in NYCHA from cigarettes, from marijuana, from vaping. The air that they're breathing is not safe. And what diseases do all this lead to? All of you have already said it. Asthma, diabetes, obesity, hypertension, heart disease, cancer. And what do? They blame the victim. Oh, these are dirty people. These people are all on welfare. And that is the narrative that they have constructed to describe NYCHA so that people will look at the victims in a bad light. And this is horrible because what we know about NYCHA, like I described to you, they are hardworking. You know how many people are on welfare in NYCHA? 13%. You know how many people are on welfare in the United States? 20%. Most of the people in NYCHA are hardworking people, nurses, veterans who have fought for our country, seniors who have paid their dues already, and we are treating them worse as subhuman. And they pay rent. We are not asking for a reduction. We're not asking for anything, just that they live in a safe home. Politicians would not tolerate this in their own home, yet they expect their constituents who pay rent, who are law-abiding citizens, who pay taxes, to have to live in this thing. And they write them off by saying, oh, these are dirty people. They're all on welfare. And that's why we need politicians to help with this, but it seems like we can't get it. And despite doing all of this, Cuomo figured all of this out. And what happened? How much money from the state went to NYCHA this year? A big donut. So I think it is important as a community for all of us to get together. And I have started doing this. I've been in contact with 50 organizations because I don't want to operate on another human being and cut out half their lung, which is avoidable. I don't want to do that ever again, but you can't avoid it the way things are nowadays. So what I have put together, and like I said, I already have 50 organizations on board with this, is a march on City Hall for safe New York City homes. That's it. I'm not asking for anything else, just that they get treated like human beings. And I think it's up to us as a society, the way we all came together for COVID to protect our brothers and sisters. This is needed now. This was needed yesterday. This is not something that's a result of COVID. This is something that has allowed COVID to infest into these areas and do its dirty work. So I'm leaving my email here. If anybody out there is interested in joining me in this fight, that's my email. Let me know. We need an army so we can finally get politicians to do their job. So that's my take on NYCHA and healthcare and COVID.
Thank you, Dr. Flores. Mr. Williams, would you like to follow up?
That was dope, man. Like, I'm just really excited right now to hear people speaking like this. I'm actually was texting my staff right now to reach out to you and make a connection to my deputy public advocates. One deals with housing, one deals with health, because this is exactly, I mean, you're hitting the nose. So, you know, I can't even, I'm just excited to be on this discussion right now, because not having to explain to folks, but people who get it, you know, right away. And what has been most frustrating is people like the mayor and the governor. And, you know, I'm sorry if I make it hot for people, but this is just, it's just the truth. There's so many things that could have been prevented even with COVID. Like, people knew and understood who was the most vulnerable, and we did nothing about it. And the governor and the mayor made decisions that made it worse. They discovered NYCHA probably about 6 weeks into COVID, when they first even started talking about the people of NYCHA and needing to be tested. And what they did, and I love that screen that showed who NYCHA was. This is what they did to make it even worse. They said those who can telecommute. That meant a very specific, unique, and privileged group of people who can do that. And then they said, the rest of you, the people who are on that list, you are now essential workers, and you have to go to work. You have to go outside. Not only that, you're going to go to work, and we're not going to give you any PPEs. You're going to have no personal protective equipment. Not only that, we're not even going to test your neighborhoods. The top 30, 25 of the top 30 neighborhoods who were tested, weeks into the COVID were primarily white, more affluent neighborhoods, and places like NYCHA weren't tested. These are decisions that our current leaders made and are pretending like they didn't make it. And so I'm all down, you know, you can get me to march quick, but I'm down to let this be the message, because this is what we have to focus on. And the people who have the ability to make these decisions are making terrible ones, and they're making wrong ones. We actually have the ability to deal with all this. I put out a worst landlord list every single year, and every year, NYCHA is on it. The New York City is the biggest and worst landlord probably in the entire country. And we have a state that zeroes out, and a federal government that obviously doesn't give enough. I don't know if we're going to get much from Trump or the good doctor over at HUD, who, if he doesn't live in the sunken place, probably helped create it. So I mean, I don't know if we're going to get.
And he grew up in public housing. And remember, he grew up in public housing.
You know, I would just add something here, and this. I did in East for 12 years and ran the primary care center that Sinai had. And I always said the biggest distance in Manhattan was between 102nd Street and 101st Street. And I could not get the care I needed, frankly, at Sinai. And I was a Sinai faculty member working with patients in Harlem. And this is a dangerous thing for us all to dance around. I think, what role do many of the large academic health centers play in this? And what more could they do? You know, I used to look out my window and just dream of trying to get better care for the community of Harlem into Sinai. And I worked for Sinai. You know, and I could say the same thing for NYU. I could say the same thing for Northwell. I could say there's a challenge right in front of every one of these large academic centers. And you know, I hope this doesn't get thrown up to Michael Dowling, but you know, we don't do enough as big academic health systems. We push it off on the county hospitals that are underfunded and are struggling to get by. And we sit back and not only sit back and look at them, we say, well, why aren't they doing a good job? Well, they're getting paid 80 cents for the same thing we get paid $3 for. And, you know, it's not a mystery that they can't do the job as well as we can because we are funded 3 times they are. It's kind of a difficult subject because we're all employed by these folks, right? So I know at least 4 of us out of the 6 are employed by these types of places. So it's a very delicate conversation to have. But I do think this has changed people. I've heard a conversation that I haven't heard before, and I hope action follows, where there's a real partnership between the nonprofit, private academic centers and dealing with some of the disparities that we all knew existed, but now the light's so brightly shining on it, people have to deal with it. So I just throw that other little touchy dynamic in there for this conversation.
Dr. Green.
Yeah, thank you. So Dr. Flores, we can certainly talk offline on how we can get the National Association of Social Workers online. This is up our alley, and as the first woman of color in this role for the city, we're on it. So I also want to say that, you know, I'm going to be a little personal here. I want us to also acknowledge that it is not just NYCHA. Myself, I had to give up my apartment in May because after 8 months of fighting in Brooklyn, reaching out to every office I can think of, including public advocate office for help, I gave up because I recognized that without power, without the right skin color, and without visibility, my landlord was going to be able to continue to force me to live in a space of mold. And I was paying over $2,500 in rent. My health has suffered significantly. And when I moved in, I did not know that within the month that I moved in this new build, that the health issues I was having was related to hidden mold. And I went through months of health issues. Yes, history of asthma, history of migraines, but I had no clue. And even when finding out, even when reaching out, if I went to my council member's office, I reached out to the assembly member's office, I reached out to the mayor's office, and got nowhere. And what I learned was that if you didn't have power and if you didn't have visibility, I would just get the runaround and all those things. So it's not just NYCHA. We have a city where we allow landlords to do what they want. the court system drags it out. I don't have attorneys on retainer, so I didn't have. I mean, I paid my entire wedding budget in 6 weeks to my lawyer to fight this case, my entire wedding budget, and remember breaking down crying because of it. But I also know I was exhausted trying to advocate for other people, being told that because of the ethnic background of my landlords, I would get nowhere. I just want to be clear that this is not just housing. I don't typically share my personal stories, but I think it's important to note that these injustices are happening not just in NYCHA, but across New York City housing, because this is a pervasive pattern and is directly impacting predominantly Black and Brown communities. And then I learned that the previous tenant moved out because of the same floods and repeated floods and mold that I moved out because of, and got nowhere, with ceiling collapsing and everything in a building that's 4 years old. And so we have to acknowledge that while we predominantly talk about Black and Brown communities, and we can refine it to a certain group, these injustices happen to Black and Brown people, regardless of how much money they make, their educational background, where they live. It's pervasive. And so when we think about that pervasive aspect, it is something that is not only traumatic, but it's impacting your health. You are not spared, regardless of your education. I have 4 degrees. It doesn't spare me from that. It doesn't spare. There are many more people like me in these situations. So I think we have to, as we talk about equity, we talk about justice, and we certainly know that NYCHA it's horrific. You're right. There's the narrative that most people that are on welfare are the ones living there. We know that's not true. Like, we know the demographics of who actually uses welfare. Like, let's just be clear about it. We know this narrative, even when we did the nonsense of, we need to test people in certain states for drug use, less than 2% of the people were using drugs. Like, substance misuse is a brain disease, and we know that, but we don't humanize it. But I also want to be clear that I'm saying this story because it's not just those who are typically considered underserved or poor. Your skin color and your area that you live in determines the access to care, justice, all the things that you would want, your social determinants of health. And it's not just where you live, it's because of who you are.
I too have experienced housing issues just the same, and I live in a co-op, but unfortunately the people who lived above me, they were renters, so they thought they could get away. And I had a leak in my apartment, and I was exposed to aspergillosis just the same. And we had a mold team come in, clean my apartment out. But that was because I had the finances to not only threaten to sue, to get a lawyer, to talk to the board, but I was able to do all of that. And that's why after a couple of years, I got them out. I got the mold out of my apartment. So you're absolutely right. Living in NYCHA, unfortunately, is not the only place where you can succumb to that, because people think, oh, well, you're just Black or you're just Hispanic, so you're not going to be able to fight for this. But we have voices and we have rights. And that's why we have to pull together, because if our brothers and sisters don't have those economic resources, that's when we have to come in and help each other out. So I think that's all right. Mr. Williams, you were going to say?
Yeah, I apologize, and I have to jump. I apologize because I'm really enjoying the discussion. But one, that's absolutely right. The worst landlord list, NYCHA was so bad we had to put them separate, and we do have another list that's for all the private ones. So it is pervasive, not in the city but across the state. And so while people were talking about Flint, Michigan, I ran for lieutenant governor, travel the state. Syracuse has some of the worst lead poisoning in the entire nation. And that's right here. So it was funny to hear the governor, the mayor, people speaking about Flint when right here we're suffering. Kings County Hospital is going to be getting rid of their gynecological oncology department. So you were talking about why a private hospital is able to do things and city hospitals are not. And so we're losing care at a time when people need it the most. And we really have to push. I am worried that we have a moment now where people are understanding what race means in these institutions. And I'm so concerned that in a few years, we might have collective amnesia about what's going on. And so I really hope we can take this moment and push all of these issues. And, my father, may rest in peace, is a physician. My sister's a nurse. My mother's a pharmacist. You never know what one incident means, race or not. But when you think of the overall of how medical look at Black folks, and the mortality rate for women giving birth is high because people don't believe their pain. My own experience after a hernia surgery went wrong and came back, wasn't believed. I had to spend 2 days in the hospital and finally had a bowel recession. And it was only because of the advocacy of my mother and my sister. They threatened to call security on them as they were demanding to have the proper treatments. What would have happened if my mother and my sister wasn't there? I was an elected official. If we weren't able to advocate, we know these stories all too well. And so, I wanted to share my personal story as well to put it out there. But these things are real. And my hope is that we can take this moment and really make some changes. But I'm encouraged by the stories I'm hearing now. And so I'm sorry I have to jump, but I just want to wish you all peace and blessings and love and light as you continue.
Just means you have to come back, Mr. Williams, that's all.
Oh, no doubt, no doubt. Peace, everybody.
Thank you. And I think that one of the things we didn't also talk about is how does this affect your mental psyche? I think you brought it up a little bit earlier, Dr. Greenford, but how, we come to work, we're physicians, we're social workers, we're in these, in these roles of professional roles, but at the end of the day, we also have to deal with these things that happen in our daily life as people of color, whether it's driving while Black, these things we were talking about in terms of housing discrimination. So how do you balance all of that?
I mean, I think you balance it by acknowledging that that's what you're dealing with, right? So I think that's the first thing. So often and too often in communities of color, there is this belief that we have to keep everything inside. And it's rooted in real survival, as if we go back to slavery and we go back to oppressive practices, in order to survive, you kind of have to make yourself invisible, right? And so that's what we've been doing for all these years. So when we're making ourselves invisible, when we're not talking about what's really happening, we're keeping things in the home, it has a direct impact. We see it. The Body Keeps Score is a really great book about trauma and the way that how our bodies manifest that, right? We see it manifest in the things that you see as medical doctors. We see it manifest in the diabetes rates. We see it manifest in the hypertension. We see it manifest in the high levels of schizophrenia and bipolar disorder among certain communities. We see the manifestation, the physical manifestation of the dis-ease that we are in. And live in. And so I think the first step is acknowledging that this is real. I tell people all the time, Tuskegee experiments are real. And while they were banned, if people think they're still happening, there's maybe some truth for that, right? In different aspects, you have to acknowledge what is happening. We know that in medicine, there is racial bias. We know that there's the concept that people of color are not feeling pain the same ways. Your neural pathways are the same, we're human. It's not changing because of the amount of melanin that you have in your skin cells, but that's the concept that we believe and that we've been told. So not only do we need to acknowledge, once we acknowledge it, then we need to make sure that we look for ways to protect ourselves. And that could be addressing our own health and well-being. And I would always encourage, I know that I'm never going to say it's easy to find a practitioner of color who isn't, I'm not going to say that. If you have 2.5%, the same numbers from 100 years ago, when before that time we couldn't get on the bus, to now, it's, what's happening in mental health and in behavioral health in general is mirroring that, right? And so I want us to acknowledge that it may be difficult, but there's also some studies that show that somebody doesn't have to look like you to understand, to be able to help you, but they have to be willing, of course, to see you as a person, as Dr. Flores mentioned earlier. They have to be willing to acknowledge your humanity before they acknowledge the very obvious skin color or the way that you present. And these are some of the same issues that we see with LGBTQ plus community, with what we don't consider normal or the norm, all those different things. Black isn't normal, Hispanic isn't normal, all of these different things. So when we acknowledge, we have to make sure that we tap into our resource base to say, hey, is there help? Where can I get help? Particularly for communities of color, we know that spiritual supports are very important, so is there a church, mosque, temple, whatever those things are that you can go to initially as a start off for help? And then when you're able to connect to those places have to be able to have then their network, because the imam, the pastor, the rabbi cannot deal with all of the serious mental health needs that are happening because that's not the way they're trained. But they need to be able to build those coalition and networks and build those bridges so that we are able to effectively put people into the systems and with the right people to support their needs. We must be willing to be conduits of help and resources. And I think that is a part that I think unfortunately is actually missing in our communities, because there's so much distrust, and rightfully so, distrust with the medical and the overall mental health system. But we have to be able to engage those spaces where we know communities are going. That's why there's such benefits and programs where people have been going into barbershops and hair salons to actually access and engage people. I know that it's been different because of COVID, but some of those networks and still exist. As I often say, like, I don't say the word socially distance, I say physically distance, because while we are all physically distanced, we are having a social interaction and we're together. And so this is a way that we can help people, and other networks can be connected to help people. But I think the systems that we know people are going to go to, or the places they will engage, that's where we need to build up and shore up those infrastructures and the supports.
So Maya, I'm going to turn to you. I know you have some questions.
Yes, so this question is for Dr. McGinn. Are there any pipeline programs for middle class or upper middle class students in college? Reference those who want to join like medical school, go to medical school, or be part of the pipeline program that he mentioned earlier.
Yeah, I mean, there's really dozens and dozens of them, and you can simply Google them and you'll get the list. At Hofstra, at the Zucker School of Medicine, we have we've had a few of the pipeline kids go to the medical school and actually join our research institute, which has been very exciting for me to see them work their way all the way from high school to graduating medical school and joining our research institute. So it's a very successful pipeline program. You just need to go to Zucker School of Medicine pipeline program and it'll pop up for you and you can do it. And they're all over the country. We need to probably multiply that by 100. As someone who spent 3 years teaching, inner city high school, I mean, we have a lot of resource allocation problems in inner city schools that kids are not getting. I think 1/3 the amount of money is spent on an inner city kid going to public schools that we see in these private schools that Roger just showed the picture of at St. Bernard's. And that we need to help them with coaching them through the complex process of trying to get to the college. Testing, which is so unfair and just, poorly done. So many issues. Anybody that's had a kid go to college, it's the most complicated thing on the planet, I can tell you. And if you don't have resources and parents who went to college, the odds of you making it through this process are so slim. And we need to do, and that's why those pipeline programs, I think, are so critical.
Yeah, I was talking to the person who runs it, and she told me that the 18th student had just got into Morehouse School of Medicine. So she was very pleased about that.
And it seems like, this is going to take forever for this program to be successful. I feel like Dr. Smith, who's the dean, and I were talking about this just yesterday, but we have kids already graduating. So we need to do more of it.
Yeah. So shout out to Gina Granger. If she's listening, she's done a really good job with our pipeline program.
Yeah, she has.
Maya, do you have another question?
You're on mute, Maya.
Yes. So what can we as people of color can do or say to help our doctors see us beyond our color?
I'll let
I think any one of you could answer that question, whether it be Dr. McGinn, Dr. Flores, or Dr. Greenford.
Raja, go ahead, give it a try. I'll follow you.
So that's why I've been organizing this march on City Hall, because I want to get a critical mass of people. And you're right, Claire, not just NYCHA, but let's say East Harlem, 33% is NYCHA, 40% are rent regulated apartments with these landlords who are, disinterested in helping people. So what I think is we have to reform the narrative or the brand of the people who live in this housing, because the people who live here have been branded by others for economic gain. And so that's why I think it's important to put together this huge coalition to march on City Hall, and at the end have people who have grown up in these environments. In my neighborhood, the Wayans brothers grew up there. Get them to speak. Whoopi Goldberg grew up in NYCHA. The CEO of Starbucks, I forget his name, but he grew up in NYCHA. There are many people who grew up in these unsafe conditions in New York City who are success stories. And we've got to make people see that this is not just a nameless, faceless person who's living here, but a real caring, loving person who has a family, who's a contributor to society. Because the narrative, the opposite narrative, has been painted for real estate companies to take over those properties for economic gain. And so we have to know where they're coming from in order to combat it. And that's why I think we need more exposure. If anything, it showed me with these marches, I got to tell you, the biggest thing that got to me, I was watching a video of a march and there was a confrontation with the police. And then someone on a loudspeaker said, okay, all white people to the front. White people went to the front to face off against the police. That told me this is not just a Black movement. This is a human movement where everybody wants justice. And so I think if we get a big coalition together to march on City Hall just for safe housing, not saying we need cheaper rent or anything like that, just basic safety, no mold, stuff like that, I think it will avalanche into other things. And I think it will make politicians realize if this is not part of your agenda, you are not getting elected, period.
And that's where the power is. And I think that's a big part of it. So I want to drill down to the question. I think you were saying that how do we, as people of color, help our medical or providers see us as people? And I'm going to go all the way back beyond the fact that it starts individually, right? Like how this person is raised. The training that the doctors are receiving is in their medical schools and training. And so I'm going to go back to how are the people being held accountable as doctors and as nurses, as PAs, as they're training? What systemic violence or oppression is embedded in the way that you're educated as a provider that tells you that someone is less than? How are they being held accountable if something happens that they may, when they perpetuate a stereotype or any of those things? Because I don't really believe that it continues to be the job of the oppressed to tell the oppressor they're being oppressed. That's a big part of it. We have been burdened with trying to tell people who are oppressing us that they're oppressing us, and then we may tick them off because of it, and then there may be some other consequences. It takes what Dr. Flores is talking about. Those who have positionality and power to use their power to create space for others, to yield their power for the greater good consistently. And until and unless allyship looks like true radical accomplice, you're an accomplice, and you are willing in public and in private to address the isms with the where you're raised, the off-color jokes, the when you see your colleague mistreat a person of color or speak down to them, we're going to have the same thing. I believe that we have a right to advocate. I have had to advocate with myself with medical doctors, and and most times I don't say what my background is or any of those things, but sometimes I've had to say, yeah, so you guys did not provide the appropriate HIPAA forms, and I will not sign off on this saying that I have received it. Oh, well, just sign it. Everybody signs it. You're actually so federal law. So then I go into that phase. And it's usually when I see somebody else who doesn't know that's then being told to just sign something. No, but we do have to give voice. But if you don't have the knowledge base to do that, or the background, yeah, I'm a provider, HIPAA inside out, I know it, fine, I can tell somebody about it. And also the fact that there's something called the Joint Commission, I know that because of the field I'm in, but there are many spaces I'm ignorant in. And so just like all of us, I would say to hold and call people out when they're being disrespectful to you. And just FYI, I know that it's a little bit more challenging because we get restricted. Unfortunately, healthcare is directly tied to your job in this country. Unfortunately, is directly tied to how much money you make. As a practitioner, I've always been frustrated when I was treating a 5-year-old who had been sexually abused that had Medicaid versus this 5-year-old who had sexually abused who had private insurance, why I got 30 minutes versus 45 to treat the same baby who's being abused. It's frustrating, but we have to raise voice. We have to hold our politicians accountable. And the same way you hold your politician accountable, you hold your doctor accountable. You can fire your doctor. I want to let you know, in the doctor-patient relationship, you have the power. We have been told otherwise, but you are the patient, which means it's your record, your treatment, your healthcare, and your insurance paying for this medical system, which means their salary is tied to you. If you don't like how you're treated, say something. If you're not comfortable saying something to that person, there's always a patient complaint board that you can go to, or the state, honestly, if you don't feel comfortable. And I'm not saying that to just use frivolous, oh, the doctor made me wait 15 minutes, but I'm saying if you are consistently feeling treated less than, and you see that you are, I would encourage you to tap deep. And I know sometimes it's so exhausting, but you do have resources and advocacy. But I do think it starts with training and accountability within our medical systems and our healthcare systems. And I certainly think that it is the job of those who have power to yield their power to make this a lot better.
So we were earlier talking about protesting to get, our feelings and points across. But of course, in these times of COVID, I think it's important to talk about how can we safely protest. I myself have protested 3 times. I wear 2 masks when I'm out, and I also wear a hat, and I maintain distance. I don't walk with people. I kind of keep to the side. But I just was hoping you guys may be able to give some pointers on how you've been able to protest and stay safe, or the advice you've given to your patients who've asked about protesting.
Well, I mean, I'll just iterate what you just said. I mean, I went with my daughter to, White Coats for Black Lives, and of course, it was mostly healthcare people, but it was actually, we met in front of Sinai, and it was, but I do think it's all the things you're talking about. I mean, if I was, I was nervous. My daughter is asthmatic. My wife is asthmatic, and I've been, working the COVID wards for the last 3 months and sleeping in, my daughter's extra bedroom and hiding and changing and all of that. So this whole process made me very anxious about going out. But as a historical moment, I think we all needed to be out on the streets. And I think just demonstrating social distancing, wearing the masks, and just, being smart about it. And the number one thing, and we do a lot on this front, Allison knows, we look at a lot of the data on this, but being outdoors is the most important thing, frankly. So the good news, and I think the reason we haven't seen such a big bump after a lot of these protests in New York, is that it fundamentally was outside. And people were fundamentally, wearing masks and socially distancing. I was very impressed. It was a biased sample of a lot of medical students, nurses, and respiratory therapists and social workers. So it wasn't, but, I mean, that's the key, and stay outside, and also it's that crunching in together that is really a big problem. And people were pretty good about it.
Yeah, I was going to say, ironically, it was more of the police officers that I was fussing at for not wearing masks than the actual.
Yeah, right. Absolutely. I actually went up to one police officer and said, "Please put your mask on."
Yeah.
He was like, "Oh, what are you doing to me here?"
Hot. And I was like, "Oh my gosh!" And I had to tell another one, "You're too close."
Of course, my wife wasn't very happy when I did that. But what are you going to do?
Yeah, I know. I was completely respectful to the officer, but
no, I was very nice. Trust me. Yes.
But yeah, were you going to say something, Dr. Flores?
I know, just
you want to get us, can you just tell us when your protest is taking place? Do you have a date yet?
So I was shooting for before Election Day this year so that we can get this on the agenda for people who are going to be running next year. But COVID threw a wrench in that. I've got a ton of organizations who are on board, and I just want to get more and more. And I'm trying to figure out how to do it in the setting of COVID, because a lot of the people who are on board with this, I'm part of a group called Community Voices Heard, which is on 106th Street. And many of the people who are part of this group are older women in their 60s and 70s who live in NYCHA, who've been the bedrocks of their families, who've raised their kids, and now they're living in the place where they raise their kids. They are the most at risk of getting sick, but they were my base. They were the ones who were going to be part of this big movement. And And I'm concerned about putting them in harm's way, because if I say it's on, we're going, they're on the street. I mean, they are tough. And so I'm still trying to figure it out. Something's going to happen before November. Exactly what? I'm not sure. I want to see what happens with COVID in the next 2 weeks. And this COVID thing is a marathon. This isn't going away. And it's interesting because now I'm operating on patients who had COVID, who were found to have a lung nodule that turned out to be a cancer. So now we're cutting out lobes of the lung that have had COVID and they have a lung cancer. So we are starting to study the tissue of the people who've had COVID, comparing that to normal lung tissue. So there's a lot of research taking place. And actually, in a few days, we're going to have something published in the American Journal of Preventive Medicine where we looked by zip code of the amount of tests done. And we found, you know, the racial disparities that you would expect in the Black communities and in the Hispanic communities compared to other communities. And so I think in this post, at least, you know, while the rest of the country, it's going up, in New York, it's coming down, and we have more of a perspective to learn from what we've observed. Once I feel like I have a better handle on it, that'll help me dictate what I think we can do with a march to bring attention, especially to the politicians, to make changes in housing and in terms of health.
Dr. Williams, to you. Next question.
Yes, so now that summer is here and everybody's like, oh, it's nice and warm. We had the protest, and I have heard people say that COVID is no longer a thing and it no longer exists. What advice do you have for people now who are no longer wearing masks? It's nice. Everybody wants to go to the park. Everybody wants to hang out with friends. 4th of July is about to be next week, and everybody's just like, let's have a barbecue. And I want to enjoy my barbecue as well. But what advice can I get from the professionals and to how to protect myself? And is COVID still like around, considering what's going on in Texas and Arizona and Florida?
Don't let your guard down.
Yeah, don't do it.
Not yet.
Listen, we're admitting patients every day with COVID in our hospitals. This has not gone away. We have a census of over 300 patients at Northwell with COVID. So this is still around, and people, I mean, I have a 19 and a 22-year-old. I mean, they're done. They want out. They want to go running around. They want to meet people. I feel terrible for them, but I am doing everything I can to control that desire to get out there. And you can. My thing is, do it, but do it smart. So, because if you say just don't do anything, you're not going to get. You're going to people. It's like the old, you know, you can never have cake again in your life. No, on your birthday, you can have a cake if you're diabetic, but you know, let them cheat. Go outside, be outdoors, no matter what you do. Number one. Number two, you got to wear a mask, you know, at every moment possible, I guess, except when you're having a beer, and no big mosh pits. That's like my rule. So, well, you know, it's hard. And the other thing is to empathize with people. It's hard. This is really hard. Oh my God, to be 20 years old and stuck in a house with your parents, like, whew.
I want to add to that. I think we have to understand the psychological aspects that are happening for people as well, with the isolation and distancing. You know, it was certainly, I think, easier to wear the mask when it was not as hot outside. You know, because it's, you know, you go outside in 2 minutes, it's stuck to your face. You know I went for a walk yesterday for an hour and I didn't wear the mask when I first left because I knew if I went a certain direction, there were hardly any people outside. Plus it was drizzling. So I was like, this is a great time to go for a walk because people don't want to get wet. But I know that when I turned the other direction, I was going to run into more people. So then I put on the mask because probably within a 30-minute walk, I passed 4 people going in one direction because I know people don't walk that way, but then I walk the other way. But I know that I have to even tell myself because I didn't go outside since last week because I've been long days of work and all of these things. So I do think we have to acknowledge the psychological implications of isolation. We're humans. We're actually meant to be in connection with people. And then it's the fatigue of isolation. It's the fatigue of the rules. Our minds, when we're first under threat, the mind is amazing. You know, when we are under threat, you know, it's going to go, you know, oxygen levels are up, you know, you're alert. But then there's something that happens when we need to try to get back to homeostasis, a balance. So we're going to tell ourselves the threat is not as bad. And I think that's what's happening. And we have to recognize that that's actually a very normal psychological process. That's what we're seeing right now with this rebellion against mask and distancing and all these other things. Because mentally, our minds need to tell us we're safe and we're going to get to safe. We were hypervigilant. We were washing our hands every 2 seconds. We were singing the birthday song, the whole alphabet song, wiping everything down with Clorox if you found it. And now it's...
You can find it. You know.
Right. Well, now I still can't find it. If you guys know where, tell me offline.
Yeah,
No,
I can't find it either.
Yeah, no one can find it still. You know, we need to get stock in Clorox, by the way. And so the reality is that psychologically we're exhausted.
Yeah.
And so part of this rebellion, this is a teenage rebellion our brains are doing. So all of us adults, you know, like literally our brains are going back to, you know, inhibitions. Like we're forgetting prefrontal lobe, forget it. I'm not listening.
I mean, your interpretation is perfect, but the sad part is this collation of the mask, like as if this is a, you know, don't tell me what, I mean, that is the sad, I mean, that was one of the most pathetic forms of leadership I've ever seen, to divide a country about masks is a political statement. What we should have had is someone brilliant and intellectual and smart like you discussing why people are tired of wearing masks. I mean, of course you are. Your brain's like, you know, come on, enough of this already. But to make it a political issue was so sad. I mean, really so stupid. I'm sorry. I'm sorry.
Nope, I think stupid is a good word, actually. It covers, that's a really good word. It is, absolutely.
Tragic.
So there are actually, I'm not sure if you guys saw the Trevor Noah videos, and there are videos of people out there going out to, like, I think it's the Florida Congress, and they're saying, like, you know, God will attack you, and it's such a dumb shame that you're wearing the mask, and it's like, you know, against like people's rights and human rights as medical doctors. And they were saying that, one of the ladies, she was saying that the doctors would go to jail for violating like people's rights. As medical professionals, like, what do you guys have to say about that? Like when somebody comes to you and was like, you're going to hell for just saying that you should wear masks. And some people say, if you wear the mask, you're going to die. But doctors wear the mask all the time.
Yeah, I think it's tough because, you know, it has become a partisan issue. And, you know, this country's very big on freedom and doing what you want. But I think this country also has shown us that it does care about its neighbor, at least a good number of people. And so it's very disheartening to see people using the freedom argument about that. It's just a mask. Just, you know what? Look at the Asian countries. They're wearing masks, and this has been hitting them long before it hit our shores. They've learned something. We need to look at them and say, well, why are they wearing masks? Well, maybe it's doing something. So it's just that simple. And it's just so sad. The state of affairs in our country is just, even a mask has become partisan. And we've got to do something about our politics. Somehow we've got to, you know, both right and left need to get scraped. It's just, it's dividing our country to a point where it's unhealthy now. But in my opinion, it's just a mask. If you think it could help save a life, just put the thing on.
Yeah.
Well, there's also
Best I've heard is someone say
that you're retaining too much CO2 and that can kill you, to piggyback on Maya's question. So if you can also comment on that, because there's a school of thought that the mask is going to kill you because you're going to retain too much CO2. So if you guys can also comment on that, please.
And I think people have, I kind of experienced one time when I had two masks on. I had an N95 and I had a thing on, and you can feel it. I haven't seen anyone pass out from it, but I think if you just have one mask on, I think it's pretty hard to get CO2 narcosis and get passed out. If that happens, you know, you see someone passed out with the mask, just pull it off and they'll start breathing. But I have yet to see that. But theoretically, that can happen. That being said, in the ICUs, all these nurses have two masks on. So I'm not sure if that is something that, if they're, it's just nowadays, I don't know what's a real concern or what's a fabricated concern. It's just tough to tell with these politics that are just depressing the hell out of me.
Yeah,
Dr.
I would
McGinn,
definitely
you're gonna say something?
fabricated.
Yeah, no, Dr. McGinn and then Dr. Greenford.
Sorry, I'm breaking up a little bit. I think it's my, can you guys hear me?
Go ahead, you're fine. Can you go ahead and
No,
answer?
I was just going to say that I think a lot of this is just fabricated to create a schism. I think it's purposeful. I think it's intentional and purposeful. And it's sad, that's all, that we've done this. The best I've heard was someone say to me, a mask is a sign of respect to your neighbor. It says, I care about you, right? And when you wear a mask, you're saying you care about your neighbor. And that's all it means. You care about the neighbor. And what's wrong with that? It's a crisis.
So I actually have a question for the medical doctors when it comes to masks. So husband and I have definitely had some heated fellowship around this because I'm like wear it all the time. But I recognize that when you're working in a environment where you may not be able to wear it all the time or change your mask, you know, if you're on 12, 24-hour shifts and, you know, those types of things, what advice do you have for people in those situations? Not only in feeling suffocating. I know just taking a walk last week with the mask on in a park, I kept taking it down because I felt I was suffocating and it was just one mask. And that's a 2-hour walk. So what advice do you have for people who are in spaces where they're in close quarters, but they're on really long shifts? How do they balance that? Because if you're not wearing it all the time, what's the risk to you, particularly as we were talking earlier about those who've been deemed essential workers? What advice do you have for that in terms of health and safety while balancing the fact that it is virtually impossible to wear a mask all day?
I mean, this does come up quite a bit actually. I'm on constant phone calls with all of our different healthcare workers are in different spaces and have I always say social distancing is a privilege, whether it's your workspace or your home. If you got a nice big office and you're the chief, okay, social distancing is quite easy. But if you're a radiology tech and you're trying to squeeze in between 3 MRI machines and you're trying to do your job, and maybe you have an allergy to contact allergy to the mask, and all these things come into play. And also, the longer you wear the mask, the more irritating it gets. So, I mean, a few things. I mean, I still think one, you try to wear the mask. 2, you got to keep washing your hands and doing all that kind of stuff. And what we've tried to do is encourage people to step outside, physically just get out of the space and take the mask off and go out. And, we have got lawn space in front of LIJ and North Shore. We even created little tents where people can go and just take everything off and just get some air and breathe a little bit. If you got to put that into your routine, otherwise you're going to go stir crazy. When I've been, working, and Elsa and I were roaming around the halls of North Shore wearing our N95s with the mask on, I had to get outside. I couldn't take it, and frequently do that. And it's just, and also a little bit of what you were talking about, Dr. Green, just taking care of yourself. Being good to yourself, making sure you get a good rest, make sure you take those timeouts. But there's no other cure for this other than wearing a mask, socially distancing, washing your hands. I wish I had a magic bullet. We're now meeting a lot, I mean, probably too much at North Shore, at Northwell, and having meetings, socially distancing in closed spaces, and people are taking their masks off, but more than 6 feet apart. But this is now, I probably shouldn't be doing that, but.
And I have one more question. And I know this was something that I was to talk about, but I think it's too close to home for me. The risk of reinfection and what then happens if you get reinfected with COVID, because we don't know what it's going to look like. So psychologically, I can talk about that stress and anxiety, but physiologically, can you share with us about are you seeing reinfection rates for all of you because of where the spaces that you're working, as well as the fact that there's a lot that we don't know? And I know I don't want to take Dr. Williams's question, but I wanted to make sure that since time is running out, that I did ask that, because I know that was posed to me and I can answer it on one hand, but I think it's because there's also a physiological component to it. Can you guys talk about that as medical providers?
Raja, it's up to you. You can take a stab at it.
I think that's a tough one. There's so much we don't know about this disease. If you got a swab and it's negative, do you really not have COVID? If your antibody's negative, did you really never have COVID? There's just too much. This is a new bug. It's only been around for, 6 months, 7 months now. So there's no expert on COVID. There's not. We don't know enough about this, and we are trying to make policy. So what we need to do is err on the side of safety. If you're not sure, be safe. And we don't know about second infections. Did they ever get rid of the first one? And it's a difficult time with a disease that we really, I think, know very little about. So I'm very reluctant to listen to someone if they're a COVID expert. We don't have any.
Yeah, I agree. I think I have a lot of family members that had COVID, and many of them are healthcare workers, and I've told them to just act as if you got to wear your mask, you got to do what you're doing. If I was a betting man, I would say over the next 6 months to a year, you're most likely not going to get infected, and I think we're allowed to take conjecture like that, but that doesn't tell me you shouldn't be careful. We have to live through a couple of years of this to learn and monitor folks. And Northwell has the largest data set of COVID patients in the world. And we are monitoring 40,000 patients post-COVID over the next 2 years to find out what are the chronic ailments. Do their pulmonary issues all resolve? Do their neuropsychological issues all resolve? Does their weakness and fatigue all resolve? And are they resistant to the next infection? And we got a lot to learn. That's why we're monitoring folks and trying to figure it out.
And I think it's important to also know is not only complications of COVID in the long term, but complications of the treatment. So right now we have a young girl who's 18 years old who has a tracheal stenosis where she's breathing through something as big as a straw. And we're going to have to go in there and cut her trachea out and sew it back together. While that's not directly from COVID, it's as a result of being on a ventilator. So we see a lot of these chronic things that are as a result of the treatment to try and keep them alive.
Dr. Greenford, do you want to comment on the psychological? There's a lot of anxiety. I mean, recently come out that that some studies have found that people after 2 to 3 months, their antibodies are gone. So what does that mean? Does that mean that if it comes back, there's no memory of what happened, so they're going to get sick again? And I think, going back to what was already said, because this is new to us in the States, we really don't know.
Yeah, absolutely. So thank you so much for answering the question with regards to the medical, because I think that what you mentioned, that there's no expert, I think that's what people need to hear as well, right? So when we think of the way that our brains work, we are always looking for safety. And so the concept that we may not be safe is something that causes a lot of discomfort for us. But I think that you also reminding us that there are things that we can do to try to mitigate the risk is necessary for people to hear. And I think that hopefully that would stop people from diagnosing themselves with WebMD, because that in itself is not good, But one of the things that you guys mentioned earlier was about going to your primary care doctor, for help. I know for myself, my doctors were not allowing people to come into the office. So there's some things that are going to be missed. So I think we have to also look at it in that context of what's happening psychologically. Typically, when we're able to find out, get an answer, it makes us feel a little better. Even if we don't like it, it's the unknown is the scary part. But when you're in a situation where you may not be able to access healthcare, or it's been, well, no, we're only doing telehealth visits, which I think telehealth is great, big advocate for it, but you can't listen to my lungs through the phone. Those types of things are real. So we have to also find ways that we can mitigate the psychological distress that we have. And some of those things are, taking walks if you can, because not everybody I recognize is in this position. Tapping into whatever higher power you have, if you have one. Making sure that you are connecting and engaging with friends and colleagues as best as you can. Again, phone calls are great. Phone's been around for a long time. It's been a great way for people to connect. I think this is a time where we also recognize it's our own self-care. And I don't mean self-care like, oh, do yoga, do meditation. Yeah, that's great. But the kindness that you show to yourself, the grace that you give to yourself, the ability to rest in your own humanity is vital. It's okay to not be okay. None of what's happening is okay. None of it is normal. And so we have to be able to recognize that as well and say, you know what, I don't feel good today. Tomorrow probably won't either, and I can't do this thing. So I think recognizing that the anxiety is normal, the depression is normal. And I did a talk last week and I shared with people, if you show me anyone on this planet, I will tell you a diagnosis, because there are no people that it ever will exist or have existed that do not walk around that I can put in DSM-5 right now. We all are carrying something, and the anxiety and the depression that we carry is normal. This is not normal. So your body's response, stress is your body and your mind's response to any demand. This demand that we've had to completely change our lives and who we are and how we operate and think is not what our brains have been designed to do for this long-term period and for God knows how much longer for the foreseeable future. So I think we have to be kind to ourselves and also tap into ourselves. I think when I did the last call with you guys a month ago, I told people, and I'm going to do it again, you cannot sigh without having to breathe. So for all those on the call, please sigh right now. You
Well, good.
automatically have to take a breath because you've breathed out, and so now you just flooded your body and your brain with oxygen. Sighing is helpful. Acknowledging what's happening is helpful. Breathing techniques are helpful. Taking a nap, that's great. Babies have it right, okay? They're
Seriously.
living the life. They have it right. Take a nap, and when you see that you may not be feeling well or someone else isn't well and you're not yourself, I want to encourage you to reach out for help. And it's okay to say you're not okay. And I want to particularly drill that down to my Black and Brown communities because for so long we've been told we cannot say it. Scream, go scream, get it out, cry, get it out. We have to get rid of these toxins. Cortisol is your enemy. Not only does it impact so many aspects, cardiovascular, all of those different things. We know that stress impacts gut health, reproductive health, cardiovascular health, all these things. It also makes you keep weight on. So for anyone who's vain and just like, I want to lose weight or I don't, it's not helping your body because it's going to keep fat on your body. It's not healthy. So we need to get it out, right? And not that vanity is connected to losing weight, but some people are like, just like, well, this is what I want to do because I want to look a certain way. No, but the reality is that it's not healthy at all. So we have to be able to acknowledge it and get it out, but we also have to acknowledge that this is not normal. Nothing is normal about the way we're living our lives. And if you can accept that it's not normal, I think you'll be much more graceful to yourself to accept that your reactions to the situation are normal.
Thank you.
I think it's now 5:31, and to be mindful of people's time, I think that's a great way to end yet another successful COVID-19 conversations. So thank you to everyone who joined us on the live, and please remember to share this. And thank you to all our panelists who took time out of the busy schedule to join us as well. Until next time, have a wonderful Sunday.
Thank you.
Thank you.